At any given moment, the CDC estimates that 110 million Americans have a sexually transmitted infection. Look at HIV incidence alone. Out of the roughly 47,000 new infections recorded annually in the United States, 21% occur in adults over the age of 50. Yet our public health protocols and implicit provider biases still treat sexually transmitted diseases almost exclusively as an affliction of the young. This age-based bias creates a massive epidemiological blind spot. Assuming risk drops after middle age, the medical system systematically ignores millions of at-risk older adults. To see how this blind spot operates in practice, we can look at a retrospective study of over 9,000 patient visits to 2 urban STD clinics in Baltimore, Maryland, between 2005 and 2010. The researchers wanted to compare demographics, sexual risk behaviors, and the predictors of acute infections in patients under 50 versus those 50 and older. Standard clinical algorithms are heavily optimized to evaluate the risk profile of a 20-year-old. They do not account for the unique behavioral and physical profile of a 60-year-old patient. By analyzing the Baltimore dataset, we can prove that these algorithms systematically mask a distinct, high-risk epidemiological profile hidden within the older patient population. The data from these urban clinics exposes exactly why our current age-capped screening habits require an aggressive update. The baseline assumption in many clinical settings is that risky sexual activity ceases, or at least drops sharply, around age 50. The data shows otherwise. This chart compares condom usage. Patients over 50 are more likely to report never using condoms, 32.6%, versus 24.1% of younger patients. The baseline for always using condoms is dangerously low across the board, hovering around 12 to 14% for both age groups. Beyond unprotected sex, significant proportions of both older men and older women reported having 2 or more sexual partners in the preceding 6 months. Older patients engage in unprotected, high-risk sexual behaviors at rates that easily justify standard, aggressive STI screening protocols. Even when older patients do contract an infection, there is a severe chronological discrepancy in how they handle the onset of symptoms. This timeline tracks the delay in care. Older patients routinely wait over 2 weeks between first recognizing a symptom and presenting at a clinic. The primary psychological drivers are a wait-and-see approach, 18.9%, and clinical embarrassment, 13.2%. When these older patients finally do seek care, physicians are confronted with a layer of non-STI decoys that further confuse the diagnosis. Medical records show frequent presentations of conditions like balanitis, lichen sclerosis, candidiasis, and atrophic vulvovaginitis, all of which mimic STD symptoms in an older cohort. This combination of delayed presentation and physical decoy symptoms makes visual assessment nearly impossible. Correct diagnosis relies entirely on systematic lab testing. This diagram visualizes overall acute STI prevalence, 25.8% in the younger cohort versus 18.1% in the older cohort. Breaking this down by gender reveals divergences. Older women are significantly more likely to be diagnosed with trichomoniasis, 21.5% compared to 13.1% in younger women. For men, the divergence flips. Younger men present with higher rates of non-gonococcal urethritis, gonorrhea, and chlamydia than older men. Overall infection rates drop slightly after age 50, but a nearly 1 in 5 prevalence rate is a massive figure. Ending routine screening for this population is mathematically unjustifiable. To find out what actually flags a patient for infection, researchers applied a logistic regression analysis to identify the exact predictors of acute STIs. For patients under 50, Black race is a strong predictor of an acute STI, carrying an odds ratio of 2.2 for men and 2.7 for women. After age 50, this predictive power completely vanishes, collapsing backward to a statistically insignificant odds ratio of 1.2. This disappearing variable suggests that older adults operate within highly divergent sexual network dynamics, or perhaps possess different acquired immunity factors built up over a lifespan. What remains mathematically constant across all age groups is behavior. Reporting symptoms and increasing your number of sexual partners always predict an acute STI. Demographic risk algorithms built for 20-year-olds fail structurally when applied to 60-year-olds, rendering standard assumptions about who is at risk entirely useless. The CDC's own chlamydia statistics report an incidence rate of 41.4 per 100,000 in women aged 45 to 54. For those 65 and over, that number drops steeply to just 2.5. These national estimates directly influenced the Baltimore clinics. Due to budgetary constraints, the clinics completely halted routine chlamydia PCR testing for asymptomatic women over 50. This flowchart illustrates the policy trap. Low national statistics prompt clinics to cut budgets and stop screening older patients. Because local clinics don't run tests, undiagnosed cases are never reported, effectively guaranteeing national statistics remain artificially low. The 18.1% acute STI prevalence we see in the older Baltimore cohort is likely a severe underestimation. The system is operating on a self-fulfilling prophecy of epidemiological neglect. Medical providers must decouple a patient's age from their STI risk assessment. First, clinicians must screen strictly based on reported sexual behavior and total partner count, disregarding the patient's birth year. Second, triage protocols need to clinically account for the embarrassment-driven 2-week delay in symptom reporting when evaluating older adults. Third, discard demographic predictors, like race, which the data proves are only statistically valid within younger sexual networks. Closing this epidemiological blind spot requires a direct approach. The medical system must treat older adults exactly as they are, sexually active individuals who are equally vulnerable to the STD epidemic.